Well, welcome again. What we're going to do is take a look at Chapter 12. Remember in Chapter 11, we talked about the steroidal agents that we give our patients, the complications that come with it, the good effects that happen. Some people, as I mentioned, are alive because they actually take steroids. Otherwise, they'd have some really issues. Well, these are the non-steroidal ones. These are the ones that don't have the same effects that the steroids do. So we're going to look at some indications, some of those that are available. Some of these have been around for a long time. Some of these are late 1990s, early 2000s, that particular point. We're going to see the various reactions and actions that happen with patients who do these. The major subcategories are cromolyn-like drugs. These are your mast cell stabilizers, and there's really right now only one that we use. Anti-leukotrienes, remember the leukotrienes sit on the mast cell, and once they're activated, they cause part of the problems that we have with people who have asthma. And then the monoclonal antibodies, these are most of the time shots of some sort. Xolair was the first one. We're going to talk a little bit about Xolair, and then look at some of the newer ones. These drugs don't replace other drugs you're taking. However, they may limit the amount of steroids that you do have to take. So some of the indications for these are prophylactic drugs. You need to remember these are prophylactic drugs. They help control mild persistent asthma. We give them to you to prevent, especially when we start talking about cromolyn during the summertime with kids and things along that line. You can see there are some cases alternatives to the inhaled corticosteroids. You can use cromolyn with infants and young children because it works well. Cromolyn doesn't work as well for adults. Once you hit about age 18, 19, you start using cromolyn. We get a lot of wheezing with these patients, so we're not quite sure what's going on with that. The anti-leukotrienes, we can use those with the inhaled corticosteroids, and if they work well, we can also reduce some of those inhaled corticosteroids. So there it is, the cromolyn-like drugs, the mast cell stabilizers, cromolyn. So it's the only one. It's also called Intol. Your anti-leukotrienes, your zarflucas, which is acrylate, montelukast, which is Singulair, Xyluten, which is either Cyflo, whatever. Your different monoclonal antibodies are Xolair, Fasenra, Nucala, Sinquir, and Dublad or Dupixent. So these are ones that really come on the market, except for Xolair. Most of these have come on the market in the last couple of years. It's really been surprising to see these. So remember that asthma is an inflammatory disease. That's why we use steroids. And anti-inflammatories, the best ones are your steroids. We need to help, though, because we don't want to keep everybody on these high doses of steroids. I remember some of the stimuli for your asthma, the IgE-mediated mast cell. When these are activated, what happens is it releases the different inflammatory mediators, things like histamine, things like heparin. It activates the leukotrienes and things along that line. You can either have extrinsic asthma, something that's outside of you, or you can have intrinsic asthma, somewhere inside of you that's causing the issue at this particular point. So what do we see with patients with asthma? Chronic persistent airway inflammation, occasional acute episodes of wheezing and airway obstruction. So we have bronchial constriction. These guys can't breathe. They can get the air in, but they can't get the air out. When you look at the x-ray of a patient who has asthma and you look at the x-ray of a patient who has COPD, it's interesting because for the most part, these x-rays almost look the same. One of the major differences is going to be the size of the heart. But both of these x-rays are going to have flattened diaphragms, and those flattened diaphragms are results of air trapping. We have mucosal swelling, and we also have mucus secretion. These guys will cough up a lot of secretions at this particular point. Most of the time, if you're going to have an asthma response, it's an allergic response to something in your environment or something within you. So there you can see most instances are primarily an allergic response, mast cells and IgE. Allergy is essentially a mistaken immune response. We're not supposed to have these. Whatever's supposed to be going on should not be causing this. And these are the different things that you can see that are released once the mast cell is degranulated. So here's some immune mechanisms involved with allergy and inflammation, some that you guys have talked about, I know, in anatomy and physiology. You're going to hear more about these when you get to advanced patient assessment also. Here's the different antibodies that exist. And there you see an allergic asthmatic response initiated by the interaction of the T lymphocytes with an antigen. And this can be either the macrophages or the B lymphocytes that are presenting it to that T lymphocyte. IgE binds to effector cells, such as the mast cell, and then when activated, that's when we get degranulation. And we see vascular leakage, what we talked about before, bronchoconstriction, mucus secretion, mucosal swelling. This leads to airflow limitations and a bunch of eosinophils that are going to help damage the airways. So the first one, and really the only one left in this family, is cromolyn. It is called a mast cell stabilizing agent. It prevents degranulation of the mast cell, okay? Prophylactic treatment and the treatment of asthma. This is one of those drugs that the American Lung Association, they have a love and hate relationship with. They really like to have it not on the formularies, however they understand it's going to be on the formularies. So they do talk a little bit about it. How do we give this? It's SVN, 20 milligram ampules, or 20 milligrams in 2 mLs, 1%. There used to be an inhaled form of this with an MDI, but I haven't seen that lately. And so what does it do? It prevents this mast cell degranulation. All drugs have side effects. It's just a matter of how bad are the side effects compared to the action of the drug. In these, we have cough, nasal congestion, wheezing, nose burning, nose bleeds, different things like that. So the other thing we can use this for is your ACE inhibitors, okay? People who have high blood pressure are on ACE inhibitors. And one of the problems why people stop taking their ACE inhibitors is it makes them cough. So how do we prevent this? We give them cromolyn sodium to be able to prevent it. It also has anti-sickle cell effects, okay? Help to reduce the blocking of the calcium-activated potassium channels. And remember, with cromolyn sodium, prophylactic may take 2 to 4 weeks for improvement in the patient's symptoms. When do we see this? A lot of times, as I mentioned, we see this with children. Baseball season, T-ball is coming up. They have allergies to the summer plants and the spring plants that are blooming and flying around in the air. They want to play. They can't because of that. So mom or dad takes them to the physician and they order cromolyn, and this should be about 2 to 4 weeks before they start T-ball. Leukotrienes have inflammation characteristics also. They're very potent bronchoconstrictors, and they stimulate other cells to get your airway edema, mucus secretion, inhibit the ciliary beat. Remember, you need to have that beat to keep the mucus moving. Remember, one of the major causes why people don't have the cilia working is smoking. If you smoke a cigarette, you froze those cilia for about 8 hours. Somewhere along the line, you've had a few more, so it takes quite a while. This is one of the reasons, too, why when we have patients with COPD, when they wake up in the morning, they'll start coughing and coughing, and, I coughed all this junk up, I don't understand it, give me a cigarette and a cup of coffee. Well, that works. And then the other thing it does, leukotrienes also recruit other inflammatory cells. So the anti-leukotrienes, okay, they're not preformed and stored. They're synthesized after a mechanical, chemical, or physical stimulus activates. And this is how they work as far as that goes. So as you can see, we still have the xyluten, the zyrofructast, and the Singulair. The problem with the anti-leukotriene agents basically is The first two, Zyplon Accolade, have a problem with the liver. So you have to be monitored to make sure that you don't have liver damage, and you cannot increase the dose that's given to you because it can cause some problems with your liver. Another major problem is not all of these work on everybody. You have to have the right IgE in order for this drug to work. So how do we know what's the right IgE? We give you the drug, we watch and see what happens to you. If it's not working, we take the drug away, we give you another drug, see if that's working. If that's not working, then we take that drug away, and we'll give you the third drug. If that fortunately works, then we'll keep you on it at that point. Otherwise, we take that drug away and you can't use those. So there's a little bit with Silutin, okay? It's an oral administration. Most of these are tablets if you go and see them, okay? It's 600 milligrams QID, which means you have to take it 4 times a day. This is not a drug that most people are going to stick there and go, oh, I have to use that 4 times a day, 2,400 milligrams. Maybe I can combine them. Nope, can't do that. Sorry. So some of the hazards and side effects: headache, abdominal pain, loss of strength, which is kind of interesting, dyspepsia, stomach upset, even on top of all the other drugs you're taking. You can see the liver function, and it interacts with theophylline and warfarin. So you got a big problem going on. Salufast or Accolade. This is the one a lot of people really like, especially those when it works really well, okay? This is also oral administration, 10 milligrams twice a day for children 5 to 11, and then 20 milligrams twice a day if it's 12 years old and older. Again, it's a leukotriene receptor antagonist. Hazards and side effects: you still have problems with your liver, we have to monitor that. Headache, infection, nausea, diarrhea, generalized abdominal pain. Like I mentioned in one of the write-ups, it's amazing. We use these drugs to make you feel better, but yet when we're giving you these drugs too, they do cause infections, and some of them cause respiratory infections. That's really kind of interesting. Montelukast singulair, this is when we see a lot of this administered. This is also oral administration, 4 milligrams and 10 milligrams, and a 5 milligram chewy cherry flavor, okay? It too is a leukotriene antagonist, and then it binds with its own IgE. Hazard side effects: diarrhea, laryngitis, pharyngitis, nausea, problems with your eyes and ears, sinusitis, viral infection. We also know, and we've seen this with both children and adults, is that this can cause some very vivid dreams. Sometimes you're not getting a good night's sleep because you're busy fighting off the dragons or whoever, and it has some issues with that because these kids and adults wake up and they're angry with the world because of what's been going on all night. So if you have somebody who's on this and they're telling you, oh, my dreams are really bad, very vivid, you may want to tell them to talk to their doctor and see if this really is a good drug for them. So what do? They protect against specific asthma triggers. It's for chronic persistent asthma. You can use them along with the corticosteroids. And then you can sometimes see the Churg-Strauss syndrome. This is a vascular syndrome. It's a rare syndrome, but it's something that can be caused by these drugs. So they're prophylactic, an alternative to inhaled corticosteroids or the cromolyn drugs. They're optimal as a monotherapy. This is not a standalone therapy, okay? You gotta have something else that you're doing. We can sometimes reduce the inhaled corticosteroids that you're taking, but you're still taking them because you need them with this, even though you got the leukotriene inhibitors. Most of the time they're safe, often effective choices. However, you've got to have the right IgE and monitor that. So some of the advantages of these: oral administration, possible one-day dosing unless you're taking the Xylutin, not as many side effects as we see with some other medications. However, remember, other medications have different side effects, so we're just adding a few more on top of what you already have. People do have aspirin sensitivity. As a result of that, they cannot take aspirin. Sometimes they can't take any of the over-the-counter NSAIDs, and they'll run into problems with that. Exercise-induced asthma is something else that we can use these through. Nice thing, they're oral, they're systemic, they will reach the entire lung. Okay? They're an additive effect with inhaled corticosteroids. It can reduce the amount of steroids that you have to take. And we do have this for peds. The montelukast is for peds. So there it is. What are the disadvantages? You only have one pathway. You have to have the right IgE. We don't know what's going on long term because these drugs haven't been around that long if you think about it. It's effective, as you can see, 50 to 70% of the patients. As I said, we don't know who's going to be able to take these, who's not. We just test you, take it away, test you, take it away, different things like that. You have a lot of systemic drug exposure. You saw the GI upset. You saw the dyspepsia. You saw the different things that happen with it too. And again, it's not monotherapy. You cannot take and use this by itself. So the monoclonal antibodies, you have to have severe asthma. You have to be certified as having severe asthma. If you don't, we're not going to prescribe this to you. Most of them are injection or infusion, okay? They're humanized IgG antibodies. The first one, as you can see, omazolulabad, which is Xolair, blocks the attachment of IgE to mast cells, and that reduces the inflammatory mediator. And then we have other ones that actually block the interleukin 5 at that particular point, treating eosinophilic asthma. So before they put this on, on these drugs, what they're going to do is they're going to check and see how high is your eosinophil count, because that tells us something about your asthma at that point, and then you also have documented severe asthma. So most of them are parental, okay? For the most part, some of the hazards and side effects, the most serious one that we have is anaphylaxis. When Xolair first came out, the FDA told the company you got to black box it. And the reason you have to black box it is because if you're getting the shot or shots that go with Xolair, you can have an anaphylactic reaction right away, or you can have an anaphylactic reaction a year from now. And so what they made folks who were getting Xolair do is always carry with them an EpiPen. Where these guys got caught, if you remember a couple of years back, the price of EpiPens skyrocketed to where they were about $700 each. And a lot of the insurance companies weren't paying anywhere close to that. The people went to Congress and they said, oh, we had to increase the money because we had to pay taxes and do other stuff. It doesn't make any sense. But you still have to have that EpiPen because anaphylaxis. Other things we see, injection site reactions, fever, headache, sore throat. Dupixent is one that you can see a rash, and depending on how bad the rash is, whether or not they're going to keep you on it. So they're prophylactic, okay, uncontrolled severe persistent asthma. They are not relievers. You cannot take these drugs and expect to solve that asthma exacerbation going on. They do not replace your inhaled corticosteroid. They are not monotherapy either. Again, what they can do is they can help reduce what else you're taking. So they can reduce the inhaled corticosteroids. If you're on higher doses of some of your rescue agents, it can help reduce that so that you're not using them quite as much as you used to. So how do we know that anything's working? If you think about it, you always have to make sure that the patient knows what they're doing them appropriately. We need to make sure that we have matched them with the correct drug, okay? These are controllers, not rescue agents. So you need to use those peak flow meters to be able to track what's going on with you. And then long term, it can help with our symptoms. It can hopefully take care of the exacerbations, ER visits, and missed work in schools and PFT changes. And we also have to assess for side effects to see what's happening with them. You may be on a perfectly wonderful drug. It seems to be helping you. But somewhere down the line, these drugs may start having side effects that are not going to be good for you. And as a result of that, then you're going to have to stop them at that particular point.